My name is Angela Brand. I use she, her pronouns, and I am with the CARE TA Center. And I am excited to welcome you into this space today. We'll be talking about MHSA funding, or Mental Health Services Act funding, specific to full service partnerships, or FSPs. We have presenters joining us from Los Angeles County, Nevada County, and Orange County. So our agenda today, we've got just a little bit of information about full service partnerships, and then we'll move right into our county spotlights with folks from Los Angeles, Nevada, and Orange counties. And these are our presenters. Just some basic background information. So the references and places to access the information that's presented today can be found in the Mental Health Services Act, as well as California Code of Regulations and the Welfare and Institutions Code. So this is just basic information on the components of the Mental Health Services Act. There are 5 components: community services and supports, prevention and early intervention, innovation, workforce education and training, and capital facilities and technological needs. The full service partnerships fall under the CSS, which is the largest component of MHSA funding. There are 3 buckets within CSS, the full service partnership being the one that's the largest. And just a little bit of information, FSPs they utilize a whatever it takes approach, which is just a complete wraparound of services that are developed in partnership with the client and their families. There's a wide array of services for children, youth, and adults. I know the folks from LA County are going to dive into those different components as well as the criteria. So I will leave that for them to cover. And we'll jump right in. So I'm going to welcome Los Angeles County into this space. If you want to say hello, introduce yourselves.
My name is Alex Silva. I'm the program manager over Countywide FSP Administration, Full Service Partnership. So as we all know, MHSA was passed by California voters in 2004 and is funded by a 1% income tax on personal income in excess of $1 million per year, which rules me out. It was designed to expand and transform California's behavioral health system to better serve individuals with services with serious mental health issues and their families. Shortly after Prop 63 passing, LA County DMH rolled out FSP in 2005. At that time, we had a little over 1,000 FSP slots. Now, let me just explain what I mean by slots. Slots essentially is the allocated or allotted placement or placement holder for services for an individual. So an individual that gets enrolled in an FSP program, we would say that that slot has been encumbered or that slot has been filled. So when I talk about some of these numbers, these are FSP slots, not partnerships. So for those of you that are my counterparts out there listening in, these are not partnerships. These are FSP slots, so available slots that we have now in LA County. So, and as I mentioned, in 2005, we had a little over 1,000 slots that were allocated based on the 4 age groups. So for child, transitional age youth, adults, and older adults. Currently, we have a total of 12,878 FSP slots across all age groups, and over 9,000 clients enrolled in our FSP program. So what we're going to be able to do today is going to be able to provide you with a little more information regarding the eligibility, the criteria that we have here in LA County. And then we're going to move on, touch upon the redesign or FSP transformation as of July 21st of 2021, as of July 1st of 2021.
Hello, everybody. So I'm going to talk to you about the child and adult programs, essentially eligibility and services offered. So with the inception of FSP, the traditional age group breakdown was child, which is 0 to 15, transitional age group, transitional aged youth, which is TAY, and that covers 16 to 25-year-olds, and adult, which for us was 26 to 59, and older adult, which is anyone 60 and over. So since the DMH FSP transformation, which we will go into much more detail later on, these age groups have merged into the following. So our child young adult, which essentially is just our child program, now covers 0 to 20-year-olds. And our adult/older adult program covers anyone 21 and over. So the referrals that were in existence prior to the redesign were now merged. So essentially we took child and TAY criteria, merged them together, and adult and older adult merged them together. So our referrals look a little bit different than some of the other counties that may be still utilizing the traditional age group breakdown. And underneath the child FSP programs, there are specialty FSP programs that also provide services, and that includes our wraparound FSP program, which has a different referral altogether, a whole different administration overlooking and processing these referrals, and our IFCCS, which is intensive field capable clinical services, and they utilize our same referral, but again, the administration is different, and both of those specialty programs need to have the client be linked to the DCFS, which is the Department of Children and Family Services. You'll see the breakdown of our criteria, and I'm not going to read everything since it is in front of you, but like I said, it has been merged with our child and TAY, which at the time had like specific reasons for each age group to qualify. And so we kind of thought this would be the best approach to encapsulate every one of those clients falling under that age group. So they have to show a seriously emotionally disturbance, so SED, and have to fall under one of these characteristics for a long period of time, and it has to be a marked degree. So the eligibility criteria, along with the severe emotional disturbance, needs to include one or more of the following things listed on the slides. So for child, in particular with hospitalizations and any history of suicide, all of these things that are required for the criteria, the narrative sections, we always stress this to all of our referring parties and providers. You really need to elaborate and expand on what this means. It's not just checking off a box. It's really painting a picture for our navigation teams, which are essentially the gatekeepers for all of the different parts of LA County, which is divided into 8 service areas. And so they really need to understand what the client is going through, since having never met the client, the referral is like the best way to gain that understanding. So expanding on the criteria is really, really important. So I wanted to kind of expand on one of these eligibility criteria with regards to transitioning into the community from restrictive setting. So that can be a hospitalization, or it can also be a short-term residential treatment placement or camps. So any child kind of getting out of that higher level of care needs to step down to a community level, which would be essentially FSP first, to continue to address their more intensive mental health needs, as opposed to just being linked to outpatient. And then as far as lacking a fixed, regular, or adequate nighttime, and that really refers to any type of at-risk of homelessness or being unhoused, not just for the child, but for the entire family. So under FSP services, you'll note that we offer a multitude of services. And I wanted to kind of expand on the child and family teams, which under the integrated core practice model, which has been adapted by Los Angeles County, the expectation is that all of our FSP teams are providing child and family meetings. So the child and family team is essentially anyone that's is the client, and anyone that is playing an active, significant role in the client's life. So it's their family, anyone from their school that they identified, mental health providers, case managers, anyone the client feels like they see as a support system. So essentially a CFT meeting needs to be conducted within 60 days of entering into the child welfare system, and must have at least a minimum of, and must be conducted at least a minimum of once every 6 months. So that can be, and it can also be scheduled at any time as long as it's being requested by the client or the team. Also something to note for us is the respite care service. So Los Angeles County DMH has partnered with Maxim Healthcare Services to provide the respite care for the family. And this service is designed to give family caregivers an opportunity to take a break from their care responsibilities of the FSP child to attend to their personal needs or the needs of other family members. So for this particular service, the child needs to be from 0 to 15 in order to qualify, and they have to be enrolled in FSP. Now, another important factor for our FSP programs is the 24/7 crisis support, which doesn't mean we're available 24/7 to the client and the family. It means that in the event of an after-hours emergency, where they need to be assessed for mental health reasons, each of our FSP programs has a after-hours phone number that is given to each client and their family to be utilized in the event of an emergency. So the team will assess over the phone, and if need be, arrive at the client's place of residence or where they are at the time of the call, and assess further for a need to place a hold and any type of hospitalization. So continuing on with the child FSP services that are being offered, one thing for us as well under LA County is our family supportive services, which are voluntary mental health support services provided to the support system of the client. And the important thing here is that the particular person who's seeking these services do not meet medical necessity for their own mental health services, or are insured and do not meet the target population for their own mental health. So essentially it's aimed to be short-term for a particular family or caregiver. But if that particular family or caregiver ends up needing their own mental health services, then the child provider can make that referral on behalf of the parent or the caregiver. We also assist with benefits establishment, any type of transportation services, housing services. We also have allocated funding that is meant to be used as a last resort should the client's family need assistance with locating housing, any type of vocational or educational services, and other community-based services. So with regards to the adult FSP programs, like I mentioned, the criteria was merged from our regular adult FSP referral along with our older adult FSP program. And under the specialty programs for FSP, we have that is specific to LA County, is our homeless FSP program, which is again under a different administration and has a different referral process. And our AOT, assisted outpatient treatment, and our IMHT program, the integrated mobile health team. So the adult FSP criteria, as you see here, it falls under the category of 21 and over. But in the event that we have a client that is identified between 18 to 20 and may not be able to get their mental health needs addressed through the child provider, we will take into account and determine on a case-by-case basis if maybe the adult FSP program would be more appropriate. And under the adult eligibility criteria, they have to have a severe mental illness, like the ones listed there, and they have to meet medical necessity for the specialty mental health services. And essentially what medical necessity means is, having Medi-Cal coverage diagnosis, impairments as a result of the covered diagnosis, and proposed interventions that will address the mental health needs identified in the assessment. Also, they have to meet either the unserved, underserved, or inappropriately served category. And just to let you know, the unserved basically means they're not receiving mental health services at the time of the referral. Underserved, they are receiving some mental health services, but these are insufficient to achieve the desired goal for that client. And inappropriately served, basically receiving some mental health services, but inappropriate to achieve desired goals because of cultural ethnic, linguistic, physical, or other needs specific to the client. We're going to break down each of the focal populations. And the first one is our homelessness or unhoused category. So when a referring party is making a referral, again, it's pretty much checking off some boxes, but we do have a narrative section that really needs to be utilized to kind of expand what it means to be, homeless or unhoused. And in this particular situation, how long has the client been unhoused? What other resources have they utilized? So it's really important for all of our referring parties to be considered of the history that comes along with each client and making sure that they're providing as much as is at their disposal too. And there's also at-risk criteria, which is a much more detailed criteria that falls under our FSP guidelines. I didn't want to include it here because it's really long, but you're welcome to look it up. We have included our links to both our adult and child FSP programs. So along with the homeless is also justice involved. So pretty much anyone that has any type of incarceration or jail history. And I want to expand on bullet point number 3 with regards to AB 109. So Assembly Bill AB 109 essentially means that upon release from state prison, the client, instead of reporting to the state parole officers, they report to local county probation. And under DMH AB 109, the program essentially is responsible to linking their clients to mental health services. And the reason why we stress this is because we do have that crossover. So some AB 109 clients, unbeknownst to us at the time of the referral, will be seeking FSP services when they actually qualify for AB 109 services, which is designed to really meet their needs. And it's similar to FSP. So we try our best to kind of check to see if they actually qualify for this program so that we ensure that they're being linked to the right level of care. We've also seen in this past 2 years with the diversion and reentry programs coming our way, a significant amount of referrals coming from particularly our Department of Health Services in LA County. So, and this really focuses more on clients that are missed or misdemeanor incompetent to stand trial. So we are seeing a larger number of referrals coming from patients who are clients who are being released into the community under missed. So this basically breaks down the high utilizers of high acuity mental health services. And as you can see, there's specific requirements for each one. And again, we understand that a lot of referring parties might not have a full history when it comes to hospitalizations because there's so many different ways of tracking. We have our county hospitals, but for fee-for-service hospitals within LA County, it's really hard to get that information. You need a release, and especially if we don't have like standard MOUs in place. So we encourage all of the referring parties to really expand with the information that they have for us. And the rest, our navigation teams can look into utilizing our DMH electronic health records and application to really look up any information that is available for each of those clients that are being referred to us. So the next few slides covers the age-specific for older adult criteria. And so aside from meeting the regular adult criteria, which is kind of expected, but not just because they don't, it doesn't necessarily mean that they don't qualify for FSP. So the next few slides kind of expands on the specific needs of that particular population, because there's a lot of factors that come into play with that population having more significant histories related to a skilled nursing facility, chronic or acute physical health needs, and anything related to cognitive stuff. So we do take that into account, and we do have FSP programs that are more specialized to serve that age group. Again, just kind of expanding on what it means for an older adult client to meet criteria for FSP, and ensuring that apart from linking them to FSP, that if there's certain needs that we can't address, we also want to make sure that we're linking them to community referrals, particularly like in-home supportive services for clients who may not be able to take care of their day-to-day needs. Because we as an FSP program, again, are not a 24/7 program. We do our best to provide at least 3 times a week of interventions, whether that be the therapist, the case manager, the psychiatrist, but for day-to-day care, we do link them to other community sources. So very similar to the child FSP services, we do provide an array of these types of interventions: therapy, case management, medication evaluation. And again, with particularly for this age group, because they may or may not have lost their benefits after being hospitalized or for a significant amount of time, or have been incarcerated, our teams really work to ensure that clients' benefits are reestablished or apply if they've never applied before for SSI and other benefits. Certain types of immigration status will likely not qualify them for SSI, but we do our best to utilize our flex funds to tap into resources to look for further resources that might be helpful for them, especially if SSI is not going to be an option. Because again, a FSP is not meant to be a lifelong program. We do have a significant number of clients that have been in our program for over 5 years. So we understand that some clients will continue to need us even after the standard 2-year expectation, 2 to 4 years, but we strive to make sure that our services are helping the client to learn to become independent and reduce the likelihood of homelessness, incarceration, and future hospitalizations.
All the information that Lily just covered is also in our FSP guidelines, and where you can locate that on our Los Angeles County Department of Mental Health's website, and the links to those to that website is at the end of this PowerPoint presentation. In 2018, this is when we started the whole process of redesigning the full service partnership program. We worked with the third sector, which was a consulting group, and were amazing. We work with stakeholder process. A lot of our legal entity contractors are part of this process, as well as UCLA, who we collaborate with to provide the technical assistance regarding all of this. And essentially, it's we wanted to make sure that we improve the system, the program as it was at that point in time. So the redesign included changes to the FSP services, staffing, funding models, increased flexibility and accountability, and more responsiveness when it comes to administrative practices. Next slide, please. We spent good 3 to 4 years, developing the redesign, the transformation. And of course, the biggest monkey wrench that we could possibly think of was the pandemic. So I'm sure that I'm preaching to the choir when everybody understands that if you have an FSP program, and the pandemic and staffing issues was the biggest issue. There was a staff attrition turnover, which completely impacted how we rolled this out. Luckily, we wanted to take a look at this in basically the next 3 years as a pilot project. So part of what we were designing or redesigning included incentivizing the enrollment and retention in FSP of those clients with the greatest need, who may be hardest to reach and treat. So that included those that were chronically homeless, frequent users of crisis physical and mental health services, and those who are justice involved, as well as those individuals that were in the child welfare system as well. Funding true multidisciplinary teams. So we have staffing patterns, recommended staffing patterns in our statement of work with our legal entities. So we're looking at, basically that multidisciplinary team, aside from having licensed clinicians, waivered or non-licensed case managers, for example, RNs, we're talking about housing specialists, substance use counselors, OT, and everyone that would be helping to assist the client in reaching their goals. Again, because of the pandemic and the issue with staffing, attrition and turnover, that's been very difficult and challenging to come to fruition for us. So we're still working on that, and luckily we've made some strides since then for our providers to be able to hire and retain that staff. Developing accountability metrics that are less focused on compliance, more focused on achieving client outcomes, including reduced systems involvement, improved educational attainment, increasing housing stability, and reducing emergency service utilization. Instituting a continuous improvement system through which DMH will collect and analyze data to drive decision-making and accountability, measure progress against critical client outcomes, and incentivizing performance targets in respect to client outcomes. July 1st, 2021, that was the day that we're going to roll this out. We're all excited. And part of that transformation again was to support our highest acuity outpatient consumers on the path to recovery and well-being. So what we tried to do was really the effort included changing the eligibility criteria to be more focused on those most in need of FSP care. So when we're looking at the at-risk, we were looking at the rest of our continuum of care. And for those individuals that through PEI, through other programs, through outpatient services, that will be able to look at the level of care and the level of need. So we're making sure that the most highest acuity, the individuals that are dealing with severe persistent mental illness actively in situations that were either homeless, they're either high utilizers of psychiatric emergency rooms, criminal justice involved, and so forth. Those are the individuals and the populations, the focal populations that we were honing in on. Changing the FSP service model to utilize multidisciplinary team approach rather than individual caseloads, began to integrate all specialty FSP programs into one FSP model. What does that mean? In FSP, when I started with FSP, I think it was in 2018, and this is prior to all the work really that was done for the most part. We had so many specialized FSP programs. We had forensic FSP, we had assisted outpatient treatment FSP, we had IMHT, which I think Ali covered a little bit about and talked about. We had every single age group had their FSP, and then some. What we realized is that the services were exactly the same. We didn't understand why we needed to have a homeless FSP program where the focal population in general adult FSP was homelessness, was criminal justice involved, was high utilizers of psychiatric hospitalizations and so forth. So it realizing later, it's like, we need to centralize all this. There's no need to have all these specialized FSP programs. So part of that was trying to merge all that. And believe it or not, after 2 years or close to 2 years of rolling this out, we're still in the process of doing that. So that's a work in progress. Lowering staff to client ratios. We're actively, meeting with our stakeholders, our legal entity providers, and listening to some of their needs and issues and concerns that they have related to providing services, specifically FSP. And at one point, they realized they were letting us know that our client to staff, lowering the staff to client ratio was fairly high. And when they have, a lot of their clients were high acuity, it was overwhelming for them. So we wanted to address that need and that concern. So we actually, instead of having it to 1 to 35 or 1 to 15 for our contract providers, we lowered it to 10 to 12 to be more realistic. But that was more of a benchmark for the most part. I think for agencies that are maximizing their contracts, we wanted to make sure that, especially during the times that we dealt with capacity issues because of the staffing issue, because of the pandemic, we wanted to make sure that for those that were able to see more clients and willing to do so, because maybe they didn't have that high acuity client list or that many people on their caseload, to be able to giving them the opportunity to make that decision. Adding funding for additional staffing to enable child. So this one is specifically for child FSP. When we did a redesign the FSP program, it was mostly focused around adults, not child young adult programs. But and what we did do is actually add additional funding to hire staff to provide the intensive care coordination and the intensive home-based services for those child FSP providers. Again, providing enhanced training and technical assistance to support FSP providers. So that's the UCLA Public Mental Health Partnership Collaborative that we have with them. And they're providing a lot of technical assistance and training. We're also enhancing services and supports to be successful in transitioning between levels of care, centralizing the authorization, enrollment, and disenrollment process. So again, this is kind of, again, with CalAIM, we wanted to just reduce the burden of documentation and making sure that our providers, the people that are in the trenches, are providing the services that are desperately needed, instead of spending most of the time documenting, filling out documentation and paperwork after paperwork, some that were duplicative. So that's what that bullet's about. Standardizing rates to bring contracted provider staff salaries closer to parity with their counterparts in ACD&H clinics. So we also went through our Finance Services Bureau, went through a huge system broad rate setting exercise. One of the issues that our providers are coming to us is that we're losing staff to you. You guys pay more than we do. We're losing staff because they're getting paid more. So we wanted to make sure that there is some type of excuse me, standard way of looking at this, and there's more parity in the salary. So they didn't have to lose staff to LA County or other providers that were paying more. Changing the FSP contracts to add incentives for providers to help their clients achieve critical life outcomes, moving our system towards performance-based contracting. That one, for the most part, was probably one of the biggest ones. And I think there's another slide that we'll get to regarding that. So again, part of all that was using data and consumer and provide feedback to drive continuous improvement. We wanted to make sure that we're focused on looking at the focal populations, looking at priority outcomes. So for homelessness, reducing, increasing housing stability. For those that are high utilizers of psychiatric department services, we wanted to reduce that. We wanted those that were criminal justice involved, we wanted to reduce incarceration rates. So that's what we're looking at and trying to use incentives in that form. This is actually just an extract from our annual update in fiscal year 21-22 that provides, again, not partnership numbers, these are slots. So again, this is the point in time. This is just as of June 30th. But as I mentioned at the beginning of our presentation, we have about 12,878, a little bit, that's exact, slots available across the county. And what we're looking to do, because of some of the capacity issues that we've been dealing with, is to maybe increase and augment some of the FSP providers that are currently in need of that, and especially in certain service areas within the county. There's some limited resources in some, and we want to be able to augment that and ensure that the individuals within that service area are being met, their needs are being met. So this is just giving you that breakdown based on all four age groups. We still report to the state, to the OAC, based on 4 age groups. But as Lalita has mentioned before, part of that was merging of age groups. So we have now a child, young adult, 0 to 20, and then of course adults, 21 plus, which incorporates older adults. So what the data is telling us is basically that DMH assessed the impact of FSP enrollment on client outcomes by measuring changes in the proportions of clients and in the number of days spent with homelessness justice involvement, psychiatric hospitalization, or independent living. Comparing a client's life before and after FSP enrollment showed the program reduces homelessness, reduces justice involvement, reduces psychiatric hospitalization, and increases independent living. These are just our websites for our LA County DMH, as I mentioned before, and below are specifically to our administration, countywide FSP administration. Just for if you have any questions related to child, young adult FSP or adult FSP, these are the links of the email addresses, that group mailboxes that you can email us at any time.
Thanks so much for having me here today. I'm going to talk a little bit at this point about kind of the rural version of full service partnership work, with a lot less zeros on the end of all the numbers. And then specifically talk about the work we are doing around housing and some of the lessons we are learning along the way, and just underscoring how important that housing connection is for our FSP work. So first, a little context setting. Nevada County is in California. Let's just start with that, not Nevada, as many people misperceive us. We are a small county, and we're conveniently right about 100,000 people. So as I talk about any numbers, you can extrapolate pretty easily to your counties. We have 3 what we'll call population centers, named cities, but none of them are bigger than 18,000 people. So really the bulk of our population lives in rural, unincorporated parts of the county. We have a lot of dirt roads, for example, in Nevada County, and many people live many miles down them. And then we have this really amazing mountain pass in the middle of our county. And as any of you who paid any attention to the weather this year know, this is pretty much what it looked like for about 6 straight months on Donner Summit. Our behavioral health department is also small, like the county. We have 3 clinics, and this is a picture of our adult outpatient clinic. And I share it because we are co-located in this facility with our adult full service partnership program. And so when we talk a little bit later about how FSP might look a little different in smaller or more rural communities, keep that visual in mind. Also important on sort of our general outline of who we are is we contract out a lot of our services. Almost 70% of our budget goes out the door in contracts. So our provider partners are incredibly important to us and to our system overall, and we work super closely together to serve our community. So specifically in, went too far. Specifically in Nevada County, we have 3 full service partnership providers. In many small counties, there are 0 providers, and so the county does the direct delivery of full service partnership services. But we're lucky enough, based largely on where we're located, and that we're a little bit bigger than some of the small counties, that we have some great providers who have been willing to work in our community. So Turning Point is our adult provider, and then Victor and Stanford Sierra serve our children and youth, kind of roughly by the numbers. I appreciated my colleagues in LA talking about sort of slots. We fund about 75 slots at Turning Point for adults who have sort of the most intensive level of need in our system. And then we have about 80 slots at Victor and about 10 slots at this point at Stanford Sierra that we fund them for kind of a next level down level of care as well. I'm mostly going to focus on our adult program because I'm going to be talking about housing, and that's really where we invest our housing resources. But one of the things I want to just mention right off the bat is when people like our board of supervisors ask us, how many people do we house in the behavioral health system? I always struggle with that answer because I look at housing support on a spectrum, and there's, literal, we own the house and we open the door and allow somebody to sleep there level of housing support. But there's a lot of other levels of housing support as well. We have arrangements where we pay a patch on people's rent so that they can afford to stay where they are. We have arrangements where, as highlighted here, we bring medications twice a day, every day to somebody. And that's the difference between them being able to stably stay in a community setting and in their housing or not. And to me, that's housing support. We know those 40 plus people are less likely to be successful in their housing if there's not somebody there twice a day helping with meds, but also making sure they're eating, making sure the furniture is still right side up, just checking in and seeing how they're doing. And that's a pretty intensive level of support that I think is part of that housing spectrum. Highlight for a second the ways that FSP might look a little bit different in a rural community than it does in LA, for example. And I think back to that picture of our clinic, it's, the pros and cons of small town living. We know each other well. You're incredibly likely to, whether you're client or staff or peer support or whatever your function may be, we're likely to run into each other at the grocery store or in town or at, whatever event. And similarly, clients are super well known in our system to both our Turning Point side of the house and our kind of county outpatient services side. And there's a lot of amazing parts to that, in that we all collectively absolutely know what it means when so-and-so ends up in the hospital, and we know what was going on in their life, and we're pretty quick to be able to figure out what intervention is going to work best for them. We know what baseline looks like for somebody and how to help support them getting back to that better place and things like that. So there's a lot of individualized care, fluidity between sort of FSP level and outpatient level, a lot of mixing and matching depending on somebody's evolving needs. And I think that's, generally speaking, a strength of being able to work in a smaller community in that way. I think also there's a lot of conversation beginning to happen around fidelity in FSP and fidelity to the ACT model specifically. And I think what we know in a smaller, more rural community is we strive for fidelity, and I think we have fidelity in our kind of culture and intentions and ways that we interact and work with people, but that staffing sometimes is a challenge at the specific levels needed for full fidelity ACT. And so leaning into the flexibility that FSP has afforded us has been really critical to operating what we think is a really excellent program through our Turning Point amazing partners. So housing specifically is what I want to focus on. So like everywhere, there is not enough housing in Nevada County. We, like a year ago, did a sort of deep dive point in time look at our FSP clients to sort of really understand their current housing situations. And roughly what we found is that of the 75-ish people at that moment in time being served in our FSP program, about a third had reasonable, relatively permanent housing. About a third had not permanent housing, but a reasonable place to sleep for the moment. For example, they're in some kind of programming like a recovery residence or our adult residential program, where they're likely to be able to stably stay for 6 to 12 months. And then about a third of our clients were not stably housed. And some of them were sleeping outdoors, some were in shelters, some were in motel rooms. But that was pretty illuminating to us as we look at sort of the growing pressures to house unhoused people who have mental health needs, and rightly so. And yet, like, we can't even house all the people in our system currently who are deeply engaged in our highest level of care. And I think that really highlights just the challenges that lie ahead of us. We have, I don't know, somewhere in the neighborhood of 140 beds that we support at that sort of varying levels of care. Probably about 65 or so actual beds that we have control of. And there's not a single empty bed ever in our system, or if there is, it's, for hours while we wait for somebody to leave a different level of care and come to that bed. And so it's not that we're managing all these empty beds and people that don't want to get in them. It's that there's not enough beds for people who want them. This isn't a newsflash to all of you, but I feel like that's not a concept that's understood well enough outside of our care system, and is really being that misunderstanding is being highlighted in a lot of the policy changes that are coming our ways these days. Anyway, enough editorializing. The other thing I want to say about housing is that housing solutions in rural communities look different than in urban communities, in part because the nature of our housing stock. Generally in rural areas, there's less dense housing. We tend not to have big apartment buildings or, larger clusters of housing. We tend to have single family units. They tend to be relatively spread out. Per the dirt road comments earlier, they tend to be far away sometimes. And so that poses a lot of challenges. It poses transportation challenges. It poses cost challenges because houses are more expensive than apartments. And it poses staffing challenges because staffing, 5 houses spread out in a 30-mile radius is a lot different than staffing 30 apartments in one building. And so housing solutions are just a little more expensive and a little harder to figure out in a rural community. And then the last bullet, I think, is probably universal, rural or urban. A lot of pressure to house people and a lot of challenges getting housing placed into community. And we'll talk more about that in a sec. Like all of you, we are trying everything we can to address the housing needs of our clients. This picture in the background is one of the few examples of dense housing in our county. It's a building that we were able to build over the past couple of years. We had a ribbon cutting about 6-8 months ago. 40 units of housing, beautiful housing, all for people leaving homelessness, 12 of which are set aside for our full service partnership clients through No Place Like Home funding. There's also tax credit funding and I think CDBG funding and a few other funding sources in the mix on this project. It was a massive effort. It was a big deal for a small county and also incredibly exciting. We, over this past year, have bought 3 houses. Well, we bought a couple of them. We funded our partners to buy some of them. We have gone after B-CHIP, CCE, No Place Like Home, Home Key, Prop 47, Department of State Hospitals, every funding source that's out there for housing, we've pretty much gone for. And it's exciting. We are adding beds, but it is a lot of work. And we are definitely finding partnerships are critical, and we'll talk more about that as well. And it's just sort of a new element of work for us as a department to really be in this housing game at the level that we are at this point. We operate a couple of what we call like a boarding care light facility. We have very few boarding cares in our county, and we have zero locked beds, 0 hospitals or PUFs in our county. And so trying to create solutions that allow people to stay in our community is one of our big focuses. So this is a picture of a house we bought this year. 6 people now live there, and we run it like sort of a few inches shy of a boarding care. So it's staffed 24/7. There's a lot of support provided to people. These are folks that reasonably likely would be in an IMD, like a long-term locked placement, if we weren't able to provide this level of support in a community setting. And it's pretty expensive to run, most definitely. But we build Medi-Cal wherever we can. And at the end of the day, it's a much better solution for people than, obviously a long-term locked facility. And it's ultimately less expensive than that as well. And so this is something we keep trying to do. We actually purchased this facility with one-time MHSA money, kind of as we faced revenues higher than we expected last year. We were able to pull out about $900,000 and buy this house. But, $900,000 is not cheap for 6 beds. The other challenge we have is really around, both ourselves as a behavioral health department and our full service partnership providers as primarily mental health agencies, really having the capacity to tackle the amount of housing kind of work that's needed. We've gone down the path somewhat often of combining a couple of providers. So we'll partner our FSP provider, in our case Turning Point, with a housing provider. We have a great organization called AMI Housing in Nevada, who works in Nevada County as well as a few other counties. And they have a lot of expertise around real estate deals, et cetera. And so we often will partner with AMI, AMI. AMI used to stand for, actually it used to be AMIH, Advocates for Mentally Ill Housing, but I think they just go by AMI now. They have their executive director is a realtor. They have a lot of expertise around negotiating housing, whether it's landlord law issues, as well as sort of quickly knowing how to buy, assess, go through title and all the things that you have to do with housing. And then we bring in Turning Point as our provider. And so that combination has worked pretty well in that it leans into each organization's expertise. It can be challenging also because there's a lot of confusion around roles and responsibilities, and sometimes it's not cost effective because you might have both organizations doing a little bit of case management. But at the end of the day, it's been a pretty viable way to move somewhat quickly on some housing solutions. And I do want to underscore again that most rural counties don't have choices like this. And so just that we're all cognizant of that. We're lucky as a smaller county to have some providers to pull into these functions. So lessons learned, lots of lessons learned. I think one of the things it took me a while to figure out as a director is that before my time, when we first started supporting particularly our FSP program with housing dollars, we didn't really understand the long-term carrying costs of owning housing and operating housing, and we didn't really finance it correctly. And I think we left providers holding the bag a little bit, and they therefore were more and more reluctant to pursue more housing opportunities with us. And it took us a while to kind of realize that's what was going on. And that's just a learning curve issue of how to build out like kind of long-term deferred maintenance funding, the whole COSER thing, whatever those letters stand for, and like resourcing for the long haul, a housing investment, I think is a lesson we learned the hard way. Again, that expertise piece. We've been lucky in Nevada County. We have another department that's called Housing and Community Supports. They do a bunch of other things too, but they have a fair bit of experience on the housing side. And so they've taken the lead on a lot of projects through the point of getting the facility up and ready to run. And then they hand it over to us and we operate it. And so they do a lot of the land use issues, the permitting, the conditional use permit, that kind of stuff. The brokering of development deals with tax credits and housing authorities and all the confusing, complicated aspects of developing housing. We're able to work together on that, which has been helpful. But it's still bumpy and we've still learned the hard way on some things. And then managing NIMBY stuff, I think, is an art, not a science. We alternate between kind of flying under the radar a little bit and, funding a partner to just go out and rent a house and move some people in. And that's that, to, on the flip side, town halls and community meetings and knocking on neighbors' doors. And I think we've had good and bad experiences on both sides of those approaches. And when we get into the dialogue part, I would love to hear from others of what you're finding is working or not working in your communities around trying to manage neighborhood resistance to housing solutions. I don't think we can talk about housing or anything in the behavioral health world without also mentioning the other massive crisis, which is the workforce crisis. And also not a newsflash, I'm sure, to all of you, but I think especially important to recognize that when we're talking about housing programs, staffing a 24/7 housing option is particularly hard, I think, especially when it's small scale, like a 6-person house where we have staff on site 24 hours a day. And if somebody is, leaves their job or calls in sick or whatever, there's not a lot of depth of the staffing model to cover for that person. And so it's really stressful on our providers trying to manage these housing projects in terms of keeping them staffed in this tight labor market. And that's another kind of stressor on the housing solutions that we feel pretty regularly. Despite all those challenges, and alongside, I'm sure, LA and all of you, it's still amazing how great the outcomes are from full service partnership programs. And this is just our outcomes from our last report from our Turning Point program. And I think if we had even better access to housing, these would be even better. But we all know this work really is effective. And I think that's the other frustration with some of the policy conversations. It's not that we don't know what to do when we're given the resources to do really comprehensive FSP level of work with people who need that level of care. people can thrive and do great and recover and live really lovely lives. But when we don't have the capacity to provide all the pieces and to provide it at the scale and scope needed, it can be really challenging. I guess that's a good lead into this. Lastly, there's so many state reform initiatives coming at us. We're all trying to sort out what payment reform is going to mean in this world. And as some of these reform initiatives and legislative solutions are coming to the table, the demand for FSP services is just going to grow. And so how do we, invest appropriately so that we can do this, continue to do the work well, and bring all the pieces together to hopefully get to good outcomes for folks.
All right, great. Thank you so much, everyone. My name is Michelle Smith, and I am the Director of MHSA Services for Orange County. So I am not the expert in this area. Chi is the expert in this area. But before we get started, just to kind of orient you to Orange County, we don't all live like the Orange County housewives. That's not us, but we are a larger county. So we've got about just over 3 million people that reside in Orange County, but we are kind of smaller in terms of geography. So that means that we're densely populated. We consist of about 34 cities across Orange County, and we offer, of course, all of the different types of full service partnership services. So we have children, TAY, adult and older adult. And today she is going to really walk you through a focus on adult justice involved programs that we have. I know with the implementation of Care Court moving forward, some counties are going to be implementing an AOT FSP sometime soon. So thought maybe a little bit of helpful information around this space would be great for you to all learn about. So I am going to happily introduce Chi Lam. And
my name is Chi Lam, and I am a program manager for our collaborative services within healthcare agency in Orange County, and I oversee our adult FSP programs. If we can move to the next slide. In Orange County, these are a number of contracted FSP programs that we have to serve the adult and older adult. The first one that we have is our adult general populations FSP, and that focuses on adults who are experiencing homelessness or at risk of homelessness, underserved, unserved, or inappropriately served. And so we started out with one location, and because of the need, it expanded over the years. And so now we actually have a total of 3, one for the North Orange County, Central, and the South Orange County. So we were able to serve up to 577 individuals through those 3 programs. We also have an older adult full service partnership, so that would be 60 and over. Similar criteria when it comes to the unserved, underserved, inappropriately served, homeless or at risk of homeless, and we can serve up to 215 individuals at any point in time. We also have a special criminal justice FSP, which I'll go into later a little bit more, and they can serve up to 197, and those are for individuals who are recent incarcerated or have history of recidivism. And so our focus is to serve that population. And a lot of them are more involved with probation and the justice partner. We also have a collaborative court FSP, and that is part of one of our full service partnership that serves our mental health court programs. And I'll go over that in one of the later slides as well. And we have a capacity to serve 135 for that FSP program. The Enhanced Recovery FSP program serves individuals who are returning from long-term community, like an IMD or a mental health rehab center. Typically, those we have the capacity of 141. However, within the 141, 32 are for our assisted intervention court. Outside of that, we do have the assisted outpatient FSP program that focuses on providing services to individuals who meet the Loras Law or AOT criteria, and that serves 100 individuals. The newest, I would say the second newest is our housing FSP program that focuses on individuals who are struggling, who have been housed, but are at risk of losing housing. And they're needing that additional support to be at FSP level of service to be able to sustain and maintain and keep their housing. And so we started again with one program, and because of the increased need, it has expanded, and now it's grown to having 3 programs and a capacity of 515. And then the latest one focuses on the cultural component. We have a large Vietnamese community in Orange County, second largest Vietnamese community outside of Vietnam. And so we're happy to be able to, got board approval to be able to develop a Vietnamese speaking FSP program. They are implemented to be able to start services come 7/1, but I know it will probably be a little bit delayed due to Medi-Cal certification and being able to make sure that they're up and running before we can actually serve. And so those are our current FSP programs. But if we can go to the next slide, then I'll go into more some of our justice involved. So for our justice involved population, we do have our mental health collaborative court programs. And currently in Orange County, we actually have 4 mental health court programs. The first one is called Whatever It Takes. So with court, earlier I mentioned to you about our collaborative court program. And so the FSP for collaborative court actually serves all of the WIT clients. In Orange County, the way that we break up the different mental health collaborative court programs between the 4 is based on the client's needs and their service needs, as well as their criminogenic kind of risk need score. So in Orange County, for the Whatever It Takes court programs, they serve clients who are homeless or at risk of homeless. However, their criminogenic risk needs that is done by probation has to have, they're targeting the higher criminogenic risk needs and have higher scores. They're the more criminal sophisticated kind of population. And so we have all of those that are in that program to come to the WIT court. The second court, the opportunity court and the recovery court, are for people who are either housed or have the ability to be housed. So they don't need that housing level of support. However, when it comes to their risk needs, when it comes to probation's assessment, then the opportunity court serves more of the individuals that have higher criminogenic risk scores versus the recovery court is more on the mix or on the lower end. The last mental health court programs we have is the assisted intervention court, and it has a lower amount because we haven't seen actually a need as much, and so the capacity is ranges at about 32, but we've been hovering around about maybe just 20. And with the assisted intervention court, we serve SMI, so they all have to be seriously mentally ill, but the criminogenic risk needs for the assisted intervention is low. So we target people who are not criminal sophisticated as much. They have lower level functioning comparing to maybe some of the other court programs. And so the services and the support we provide are a little bit different compared to that of like the WIT population. So with the enhanced recovery FSP, which I mentioned earlier, that has the capacity of 141, 32 of that goes to the assisted intervention court. So through that collaborative court process of identifying individuals who are needing that court supervision beyond formal probation, once that gets determined, they get referred to be evaluated. And once they are evaluated by our team, through the collaborative discussion process with probation, with public defender, with our district attorney's office, and with the judicial officers and the court and the judges, they may get admitted into the AI assisted intervention court, and then they get referred to our enhanced recovery full service partnership to get services. With this particular program, we do have a county psychiatrist that provides the medication services component. So the FSP provides every other services except the medication component. And our county psychiatrist provides that and participates in court staffing and court hearings and being able to provide updates as well for that group. The collaborative court FSP, which I mentioned earlier about having the 135 capacity, they provide actually all services to the clients who are admitted to the WIT court. So for this, all of FSP services, including case management, therapy, groups, medication, they're all handled by one full service partnership program. We work closely with all of and one of the successes I think with our mental health collaborative court is just the close collaboration that we have with all of the different partners. Not just with our community-based organizations, but they work closely with the public defender, the district attorney, probation, really being able to cross-train as well as help them to better understand each of those roles and being able to focus for us on the treatment aspect of it and looking at from the treatment perspective and making recommendations for the court, and they can then be able to kind of make the decisions on what can be done to support that the individuals to advance. And upon completion of the collaborative court program, then their charges get dismissed, and then they are able to we connect them to either a lower level of care or different FSP programs if that's what they're still needing, but are no longer needing the court supervision aspect of it, then we transfer them to another FSP program. But a lot of our individuals are able to successfully graduate from the court and then also discharge to a lower level of care. The next slide is our pretrial mental health diversion, and this came about in late 2018 based on AB 1810 with the Penal Code 1001.36. Based on that particular, when the legislation came out and in Orange County, we were looking at how do we support and work with our community partners as well as our justice partners to be able to develop a program that can help support that. And when we first implemented it, all of the different judges from the different courtrooms would be making the referrals through our public defender's office. We work closely with the PD office to get referrals directly through them and through that office because of managing the numbers and looking at, you know, what is that going to look like? Because nobody knew how much it will be or how many that we will need to kind of help. And so through that particular process, we ended up getting, I think, average maybe 2 or 3 referrals a month because it wasn't really a lot. But what we found during that time is different judges had different interpretation of that as well as requirements and treatment, and they really didn't understand kind of the service need. And I think as in Orange County, as we went through that for a couple of years, what the collaborative partners and our court decided to do is that they ended up centralizing it and being able to identify one courtroom with one judge. Then they worked on having dedicated public defender to support this process and being able to have a dedicated district attorney to be able to participate in this whole process. So then it really did help to streamline that process as well as to make it more efficient, as well as being able to, I think, manage the referrals and the cases that comes in. And even within our healthcare agency, we started with borrowing staff from another program because when it first started, we didn't have physicians. And then over the years, as it continued to expand, we were able to identify additional staffing and support. And I'm happy to report that we actually have identified 2 clinicians to be able to be court liaison, to evaluate, to link the clients to services. Our clinicians actually, they don't provide direct treatment because they act in more of a court liaison role as well as evaluating them for appropriateness. What we did is, depending on the client's needs, if they are needing a county clinic level of care, we would connect them to a county clinic service. If they are needing FSP level of care, then we would connect them to our existing FSP, wherever that can best meet the client's needs, as well as the cultural language and other factors as well. But outside of that, we look at our criminal justice FSP, which I mentioned earlier, being able to serve those who have recently been incarcerated or maybe have probation involved. We work with them to expand their contract. And so we were able to increase their capacity and increase slots for them to be able to serve a lot of the pretrial mental health diversion. The goal was being able to help them to successfully graduate from pretrial mental health diversion court and be able to then continue and not going through the justice involved and criminal justice system. And so for us, we have been able to continue that effort, and it's been going really well. And I think what we've been seeing is because of pretrial mental health diversion being expanded and being a more of a go-to route, we're seeing that we are getting less referrals for the mental health court programs because many people want to be referred to the pretrial mental health diversion track first. So I think we're seeing kind of shifting in numbers, and we've been monitoring that as well to kind of look at how that impacts services, as well as where we need to dedicate our resources based on kind of the trend that we're seeing. So, and then the program stats just provide some additional kind of referrals so you can see before they centralize it over to the community court building, and then also after they centralize it over to just under one court building. Our AOT program. So another justice involved, this was back in 2014 when we implemented AOT in Orange County. Part of that effort is being able to, when we develop it, we have a county AOT assessment and linkage team, but we also had our CBO contracted program to serve the clients who meet that population and meet the criteria. And so we call it, that's our AOT FSP program. Just some uniqueness of our FSP program, not just that they serve the AOT population, but one of the things that I wanted to highlight is for that particular FSP program, we have a court involved track. So those that are court ordered to participate in the treatment, who've gone through and they are supervised by the AOT court. We also have a voluntary track for those who actually, once they complete AOT court track, they can then just stay in the program and go into the voluntary track. So we don't need for continuity of care, as well as just to be able to continue to engage this individual and ensuring that they're continuing to get the services. And a lot of the times they already develop working relationships with the program and the FSP. And so for us to be able to have that voluntary track so they can just transition to that track seamlessly without needing to go to a different program and having to develop that relationship all over again. So I think I wanted to highlight about that with our FSP program for AOT. Outside of that, our AOT program, FSP program actually provides more field-based services than comparing to some of our other general population FSP programs. And what has really helped is even with their psychiatrists going out to the field, being able to engage the individuals, which we find really helpful and for our members, and it builds trust as well as just kind of building that rapport and developing it. Additionally, even though we have peers in all of our FSP programs, AOT has the most peers, just to highlight that piece and how helpful it is to be able to have peers involved as part of an engagement, as well as part of that multidisciplinary team to help the individuals really connect with them and being able to walk with them, share their lived experiences as well. Within this particular program, we actually have different team leads that support the staff members. And in AOT, we actually have a peer team lead that supports all of the peers in the program and bringing that expertise as well as that supervision and support to the peers, which we find definitely helpful. And then on top of that, family is a big component of our AOT program. And so we support that by providing family nights, family therapy, being able to make sure that we have someone who is experienced and to be able to provide that support. Additionally, for family members, because what we find is a lot of family members are the ones who are making the referrals, and they're just having a lot of challenges in helping their members, their loved ones. And so being able to provide that extra support from the family to the family has been helpful for our AOT program. At the bottom is just some of the stats stats that we have tracked over the years, how many referrals that came into our county team, as well as with our county programs, our AOT staff at the county level, being able to actually engage our clients to be able to then link them to voluntary services before we refer them to the court involved. So I think we've been successful on that end as well, to be able to connect them and prevent them from being court involved or court ordered. And over the years, 213 court involved members, majority of them are through the settlement agreement, but we've had some that are contested, and so ended up all of them being court involved, which are the 32 that you see. And I think that is it for, at least for me. I believe I'll hand it over to Michelle for the remaining slides.
Putting this information together, I started thinking about this from the MHSA lens. And so as the person that is responsible for the vision and the coordination and the storytelling of all of the good work that's happening around the Mental Health Services Act. And the full service partnerships, of course, are a significant part of MHSA, representing, the majority of the CSS funding. And so there was a couple of things that I just really wanted to touch in on. And now that I'm looking at this, it's really hard to see this on the slide, but it's really just a breakdown of a couple of things. So if you look at the snippet of our spreadsheet, I've had some conversations with counties that are going to be potentially having to be part of the first cohort implementing care court, or folks that are actually starting an AOT program, and this anxiety and a little bit of concern about this perception that there's going to be this influx, this huge number of people that are going to be knocking at our door, they're going to be wanting these services. And so to support the breakdown, the storytelling, as well as to be able to kind of hopefully appease some fears, I wanted to give you really what that looked like. So if you look at just our half year on that, all the way to the right column, we received about 262 calls and referrals. Of those, a little bit over a half actually resulted in a referral. As she indicated, majority of those referral sources came from family members, but really it was from a treating or supervising mental health treatment provider. Those were the folks that maybe referred over. And so that probably is a pretty good kind of a referral, because those are the folks that are referring. And so sometimes you might get from an inpatient hospital, or some kind of justice involvement, or a judge, those types of things. But being able to put a system in place to kind of track where things are coming from is very helpful, because especially if you could take this information and realize how many of, from who, if it's a good referral that's coming in, and there might be some education. If it's you get 100 referrals from some source and none of them are good referrals, then that you can do some outreach and some education. So it's really being able to have those systems in place so that you can engage your stakeholders early and often, create what the structure looks like, have a lot of information and education out there, so that as your system partners, as you erect your programs and start moving them forward, they know exactly what a good referral is for, who qualifies for what kind of program, and if they have questions, then they know who to call and ask those questions of. So really, out of those, for our half a year, the 262 calls, maybe 150 of those, just a little over half, were a good referral. For those folks, 55 of those actually accepted voluntary services. Majority went into an FSP. We had some that went into clinics, and then other resources as well throughout the system of care, depending on what was appropriate for those folks. I'd like to really you to take a look this year in terms of the actual number of people that were involved in something that was a court involved case. It was 2. I don't want you to freak out and think, oh my gosh, we're going to be inundated, right? I mean, I think that a part of what needs to happen is that good education and communication with all of your partners and your stakeholders, so that they have a good understanding. And then further on the down on this list is just kind of giving information about why those leftover people, why they were not engaged, what happened with them. Some didn't meet criteria once they were referred. Others were maybe incarcerated, unfortunately, or an extended hospitalization. And sometimes we're just unable to locate folks. And so just giving you a good sense of kind of the flow of how this might work for your county, and being able to track that information so that you can track how this flow is happening for your county and be able to kind of tell that story at that high level and answer to your stakeholders as you're doing MHSA planning. So they might be interested in this. Being able to, again, offer multiple forums for feedback from clients and providers, talking to the folks that are actually the recipients of the services, the family members, all of the people that are involved. Orange County is a very diverse county. We have 6 threshold languages. And so that I think that speaks to the diversity of our county. And so making sure that you are leading with an equity focus and offering like cultural competency, engagement strategies that make sense for the population that you're serving, and paying attention to that, especially when it's, folks that maybe are harder to engage, and the use of, I think the use of the peers that Chi was talking about is a good example of that. So folks that understand, that have my lived experience, that can relate to me in a way that others can't, is gonna really do well for you. Being able to provide positive reinforcement for your clients. And then, of course, from the administrator piece of me, right? Just being able to standardize things as much as possible, like the referral process, discharge, follow-up, just kind of having a good standard flow so that you kind of know all of the moving pieces. And if something gets bogged down, then you have a system for being able to identify, where things need to, where they're getting bogged up and why. Being able to establish systems for information and analytics tracking, and making sure that if you can, that you have actual people to do that. It's not somebody, it's not just, it's not Chi's job and then she has this other job where she's tracking the analytics as well, right? So just being able to actually have the appropriate infrastructure and staff. I know that's a lot of times a luxury, especially when we prioritize delivery of services to people. I mean, that's what we're here for. So, but it really is smart to invest in the front end on making sure that you have that administrative support, the analytics support to be able to move forward. And then being able to create some communication tools to kind of explain flow and process. And it doesn't need to be anything fancy. I mean, they can be internal communications, external. If you go to the next slide, I'll show you what I mean. Nothing fancy. However, and again, that's kind of hard to see. This is just really the flow chart, the decision making of how somebody would come into our system, right? So call this phone number, communicating with our partners. You call this phone number, they don't meet AOT criteria. This is for, assisted outpatient treatment. We would link them through other community resources, through our OC Links program that helps us people to actually link and navigate resources. If they meet the criteria, this is the flow of that, and then so on and so forth through everything. So this is a really easy tool to use for communication and being able to help folks understand how programs work.
And with that, I'll say, everyone, have a wonderful afternoon. Thank you for joining us today. Stay well, and we'll see you next time. Thanks, everyone.